Let me ask you a couple of questions, all three of you. You mentioned, Dr. Manns, that you have 300 local volunteer community health workers that you've trained, who in turn have educated some 150,000 Liberians about Ebola prevention, detection, and care. In your statement, Mr. Torbay, you talk about to ensure the availability of adequate, well-trained, well-protected healthcare workers. How close is Liberia, Guinea, and Sierra Leone to having an optimum number of healthcare workers who are adequately trained? What is the deficit? I mean, this is excellent information and very encouraging information. Are you finding people have been scared away because of the fear of contracting it themselves? So if you could provide that information to us. Secondly, Mr. Sedgwick, which I would point out parenthetically, we're both from New Jersey. Welcome. Mercer County. Let me just, which is where I'm from. Let me just, you talked about the safe body management is of the highest priority to stopping the spread of Ebola, and you pointed out the CDC number of up to 70% of cases originating from contact from the deceased. And I think a lot of people are not unaware, but they have not known how stark the transmission is at that period of time when somebody has passed away. And yet you have very good information about your teams reaching 96% of bodies within 24 hours over the last month. How many of the folks that should be reached are not being reached, just to try to get a sense of the unmet need? And what is the role that clergy and church are playing? Obviously, when somebody passes away, we all turn to our faith. The church plays a key role, obviously, in funerals. What role are they playing from the pulpit and any other way of getting that message out about the contagious nature of someone who is deceased from Ebola? I also, with regards to personal protective equipment, Mr. Torbay, that's your third point that you made. How available is it, especially to those volunteers and those indigenous individuals who might not have access to it like some of the NGOs might going in? If you could just speak to that. Are we where we should be, anywhere close to it? Because obviously that's one way of protecting. And then Dr. Manns, you had mentioned, and rightfully so, the deep concern. President Sirleaf, when I spoke to her, raised the concern, as you have echoed her concern here today, about other diseases that continue to take a devastating impact on people in the three affected countries, including Liberia. And congratulations and good work on the safe delivery aspect to help both mother and baby have a venue where they can give birth as safely as possible. And as if you might want to expand upon that, how many women are we talking about who have gotten help through your work? I have other questions, but I'll ask those first and then yield to my friend and colleague and then come back for a few others.
Thank you, Mr. Chairman, for your questions. I'll start with the health workers gap. What we're doing at International Medical Corps is focusing on training health workers that will be working in an Ebola treatment unit. And that training is a 14-day intensive training that includes hands-on training, actually treating patients in an Ebola treatment unit. And as you probably know, when you work in an Ebola treatment unit, you cannot work for more than an hour or maximum 2 before you get out because of the heat, because of the pressure, because of the stress. And we want to make sure that those workers go out before they get tired and dehydrated, because this is when mistakes happen. So we're extremely careful about that. In terms of the healthcare gap, we're coordinating with agencies that are doing community work, such as Global Communities, Africa, and other groups, and Samaritan's Purse and other groups as well. And the idea is to combine and coordinate the community-based approach with the treatment-based approach, because one cannot work properly or be effective without the other. As you know, Liberia and Sierra Leone, even before Ebola, had very low doctor per patient ratio. We're talking about one for 100,000 in Liberia, one doctor for 100,000 in Liberia, and that's before 324 health workers have died from Ebola. So you can just imagine the gap. One thing that's critical to the health gap, we cannot be only reactive. Anytime there's an outbreak, this is when we decide to train. We need to build a stronger healthcare system. We need to build a stronger preparedness system in all of these countries, and we need to focus on health workforce development. Because again, it's not just the infectious diseases, it's the malaria, it's the safe delivery, it's diarrhea, it's everything it's vaccine preventable diseases that children are dying from. I think we're on track in terms of training health workers for the Ebola response, but what we're doing in our Ebola treatment or Ebola training facility is that we will be turning it in the next couple of months to an infectious disease academy that covers much more beyond Ebola. And this is the sustainability aspect that we're encouraging all of our colleagues to look at, what comes beyond Ebola.
Thank you for your question. To address your second question on unmet need, I'd like to point out that the 96% of bodies that are collected within 24 hours, that's within 24 hours of the death of the individual, not of the phone call. So much of that 4% is regards a delay between the death and the phone call. And the assignment of the team. And so that's a big effort that we're working on in terms of our social mobilization and the social mobilization that all of the other partners are doing to ensure that that phone call happens very early on. Ideally, we're hearing about the status of the individual well before they pass. And as much as possible, our success is made significantly easier by our colleagues like IMC running ETUs and having the volume and the beds available to treat those individuals. It's much better for the individual to get to the ETU, to get first community care, and then get to the ETU, and that makes that allows our teams to do a lot less work, which is a great situation to be in. In terms of the larger question of unmet need, it's very difficult to understand. We do a lot of work with the communities trying to understand if there are people dying that are getting hidden, and it's all anecdotal. I know that the African Union and the CDC have been working on doing some studies on this, and they've found limited volumes of people hiding, but any are devastating. So we're really working on making sure that the stigma goes down, and which would encourage everyone to call and to reduce that unmet need. In terms of volume, we are completely mobilized, and we are able to respond very quickly. We've mobilized new teams within a day, so we're able to make sure that as hotspots come up, the teams are positioned and available and responding immediately. On your second part of that question regarding clergy and faith-based leaders, they're a core part of how we interact with the communities. Our kind of historical interactions in Liberia have been focused on Bong, Lofa, and Nimba counties. And so we have really strong relationships, not just with the religious leaders, but with the traditional leaders and with the health leaders. And that made our initial entry with burial teams fairly straightforward. You can't drive one of our vehicles through those counties without getting stopped and having them ask, how's so-and-so, and how's so-and-so's baby, and they're so engaged there that it made it very, very straightforward. When we moved to other counties, especially in the southeast, where we have less of a historical presence, we very quickly realized that we had to do really extensive interactions with the religious health and traditional leaders. And they've been incredibly helpful in making sure that the communities know why we're there, that we're there for a good reason, that we're helping, and that we're able to do our work respectfully and closely and rapidly. And so that's been a core part. The religious leaders have been really helpful, and the traditional leaders who also serve very important roles at the community level have been very important for making sure that our teams are able to operate rapidly and safely.
On personal protection equipment, no, we are nowhere near where we need to be. There are shortages of all kinds of equipment, including gloves for medical personnel to use. So what Africare is doing is working with the private sector here in the United States, the big suppliers of equipment like J&J and so many others, to be sure that we can get a steady supply of consumables into all health facilities in Liberia, working with all of the NGO partners, because we are a big believer in collaboration, that no one of us can do this alone. And second, on Safe Motherhood, you may know even before the Ebola crisis, Liberia had one of the highest rates of maternal mortality in the world, and headed in the wrong direction, increasing. So a big focus for us has been in building more and more of these maternal waiting homes, working with the private sector in Liberia to raise the money to do so. And so far, I think we're up to about 20. And in these facilities, the point is to bring access to communities, because women who were expecting were not able to get to these health facilities, which are so few and far between. And that's something we intend to do, continue to do post-crisis.
Ms. Bass?